Other critical factor that I mentioned, the second element in successful advocacy. What do we mean by that? For example, it is important to build the capacity of the key players who will contribute to that advocacy program. Sometimes we call them champions for that cause. These champions can be individuals or groups across various sectors, but they should be credible, should have informed and engaged voices on that particular issue. How do you build that informed voice? Very often, we do build it through experiential knowledge. For example, it is very useful to take your stakeholders, your policymakers, to another state in the country, which is doing innovative work in that particular area, or to another country in the region or elsewhere. It's when you experience firsthand, you create awareness, you leverage those learnings, and you generate commitment and enthusiasm to bring about change in your own environment. Sometimes you can also have some training programs which you organize at the national, state, or community level. I'm a great believer in community level experience because that is always a very useful way of building the experiential knowledge of an individual. But I would like to add that it is not, advocacy is not a one-off occurrence. It is a process of ongoing interactions between various actors as well as internal and external factors. So, apart from mobilizing the policymakers and decision makers, it is also critical to create a conducive environment around you. You know, Mr. Ketkar referred to it. Health news doesn't get such high TPR ratings. But we have to create, when we take up a public health issue, we have to create what's called a buzz around it. If the general public begins to read about it or hear about it on TV, they do begin to form an opinion. It could be negative or positive, but you form an opinion, you take a position, and sometimes, or very often, you then begin to also demand the change that is required. So I do have many other examples, but I think there is not enough time to talk about examples. I think you have got a general sense about what advocacy is. What I have focused on largely was what was general and political advocacy, but what we also do as part of our work is media advocacy. Very, very important. Media plays a very important role in setting the agenda, in shaping public discourse around issues, including health and development. So when it comes to public health, the Indian media can play a key role in framing health as an urgent and important issue, something that is not happening right now. And we heard that from a senior media person himself just a few minutes back. So media can put pressure on decision makers to prioritize health-related policies and programs. So we work a lot, we engage with senior editors and journalists. We do this through one-on-one meetings, as Mr. Ketkar said, just come and talk to us about it. We organize roundtables and workshops. We bring up these issues with the hope that the media engages with your public health issues much more actively, and that the discourse is raised at the national and the regional levels. I will conclude. As I said, I had some other examples we can talk about later, but I will conclude now, and I will say that having said all of this, it's not easy. There are many challenges when it comes to advocating for public health in India. Sometimes the political climate is not conducive or open to addressing a particular health issue. Sometimes there are dissenting voices and misconceptions amongst the general public that refutes scientific evidence on the need for certain health interventions. We are just recently seeing this whole debate and discourse around the measles vaccine, for example. Sometimes, due to cultural and social norms, some issues are not given the prominence that they deserve, such as women's health and rights, something that is very close to my heart. Sometimes, in spite of the government's best intentions, the resources are simply not there to implement or to scale up a public health program. And sometimes diverse parties, who might all be interested in the same cause, are working in silos, with no dialogue between the sectors or the stakeholders. And we see that in the government itself, between the different ministries. But because of these challenges, the need for advocacy is all the more important, because advocacy can create a conducive environment for change. It can work to correct the dissenting voices, and it can promote accurate and evidence-based, very important, evidence-based information about public health. It can sensitize stakeholders and the public about the reasons why that change is needed, and it can bring about a shift in the mindset. It can also help to mobilize resources from diverse parties. It can, above all, mobilize the voices of the people who can themselves then demand or push for change. It can bring groups and people together across sectors, across party lines. And we have done that because when we work with parliamentarians or decision makers, we do work across party lines so that they can all be committed. It can be one party today, it can be another tomorrow, but they can all work or have that information available to work for that common united goal. And this is where the true power of advocacy lies. So against tough conditions or sometimes very heavy odds, it can have a real-world impact. It can drive change that will reach the people who need it the most. Sometimes what we think is impossible, advocacy can make possible. Thank you very much.
Thank you, Sushma ji, for addressing the audience about how advocacy plays such an integral part within the realm of public health. And Dr. Soumya earlier also referred to the importance of research at the ground level. I now invite Dr. Pradeep Krishnatre, India Director for Johns Hopkins Bloomberg School of Public Health, to present us his research, which was a case study. Thank you.
Thank you very much. I had a PPT presentation ready, but when I was told that there would be almost 750 people in the audience, I was suddenly surprised, and I said, we are living in an age of TRPs, and I must make sure that, what I speak actually makes sense to several of you people here. So what I have done is, I will not be using my PPT, Dr. Ruchi, if you allow me. What I'm going to do is to summarize, in the limited time that is available for me here, to summarize, my experience as to how research addresses some of the very important questions that we health communicators are confronted with almost on a daily basis. So I have 4 questions. Let me start with the first question. A very fundamental one. Why do people behave the way they do? In health communication, in marketing, and in other disciplines also, this is a question. We want to bring about behavior change. We want people to move away from their current practices, especially if those current practices are not very positive, are not very desirable, and in fact, can have adverse impact. So, and how them to get to change their behavior and practice desirable behaviors. Now, there are certain important theories and constructs that have told us about why people behave the way they do. Given the limited time, I will just identify 3 or 4 main factors which almost in any health context apply. One is there's something called a subjective norm. Plainly speaking, what it means is, what is it that I think is important for me? What is my belief? If I believe that the current practice, that the current behavior that I practice is good enough for me and hasn't had any adverse impact that I can realize, feel, then I will continue to practice that behavior. So subjective norms in that sense are very important. Each one of us has, some values, some norms, some practices, and if we believe, if we feel that, those are good enough for us, then we will continue to practice the way we have been doing it. The other, but subjective norms is not the only thing. There's something called social norms as well, which is, what my wife feels, what my neighbors feel, what my immediate group feels, what is the significant other that that they think that what I am doing. If these significant others, the social norms in that sense, believe that, my practices are not in conformity with what the accepted social practices are, then chances are that, I will change my behavior, chances, okay? But if the social norms are in alignment, are in sync with my own subjective norms, then I will continue to practice the behavior that I have. And despite, what health practitioners tell me, what medical science tells me, because there is always a constant tension between cultural interpretation of disease and a biomedical, understanding of what disease is. And more often than not, there is a paradox there that we tend to go along with whatever cultural interpretation of disease is. The third factor is something called self-efficacy, which is, can I perform the behavior that I may ask to perform, especially if that behavior does not conform with the behaviors that I'm currently practicing. Okay, do I have the skills? Do I have the competence? If I have that, then maybe I will practice those behaviors. Several smokers, cigarette smokers, perhaps want to quit smoking, but they don't know how to. So health communication can facilitate this behavior change. There is also, lastly, there is something called an optimism bias, which is, any adverse effect that will happen to me because if I smoke, because if I indulge in extra, marital affairs, I will not be infected, but if a similar behavior is being practiced by somebody else, that other person will be affected and not me. All of us at some time, most of us, not all of us, most of us, especially if you are young, tend to believe that, this is not going to happen to me. If I drive a car very fast, if I drive it to school.
Referred to the importance of research at the ground level. I now invite Dr. Pradeep Krishnatre, India Director for Johns Hopkins Bloomberg School of Public Health, to present us his research, which was a case study. Thank you.
Thank you very much. I had a PPT presentation ready, but when I was told that there would be almost 750 people in the audience, I was suddenly surprised, and I said, we are living in an age of TRPs, and I must make sure that, what I speak actually makes sense to several of you people here. So what I have done is, I will not be using my PPT, Dr. Ruchi, if you allow me. What I'm going to do is to summarize, in the limited time that is available for me here, to summarize, my experience as to how research addresses some of the very important questions that we health communicators are confronted with almost on a daily basis. So I have 4 questions. Let me start with the first question. A very fundamental one. Why do people behave the way they do? In health communication, in marketing, and in other disciplines also, this is a question. We want to bring about behavior change. We want people to move away from their current practices, especially if those current practices are not very positive, are not very desirable, and in fact, can have adverse impact. So, and how them to get to change their behavior and, practice desirable behaviors. Now, there are, certain important theories and constructs that have told us about, why people behave the way they do. Given the limited time, I will just identify 3 or 4 main factors, which almost in any health context apply. One is there's something called a subjective norm. Plainly speaking, what it means is, what is it that I think is important for me? What is my belief? If I believe that the current practice, that the current behavior that I practice is good enough for me and hasn't had any adverse impact that I can realize, feel, then I will continue to practice that behavior. So subjective norms in that sense are very important. Each one of us has, some values, some norms, some practices, and if we believe, if we feel that, those are good enough for us, then we will continue to practice the way, we have been doing it. The other But subjective norms is not the only thing. There's something called social norms as well, which is, what my wife feels, what my neighbors feel, what my immediate group feels, what is the significant other that feel that, that they think that what I am doing. If these significant others, the social norms in that sense, believe that, my practices are not in conformity with what the accepted social practices are, then chances are that, I will change my behavior, chances, okay? But if the social norms are in alignment, are in sync with my own subjective norms, then I will continue to practice the behavior that I have. And despite, what health practitioners tell me, what medical science tells me, because there is always a constant tension between cultural interpretation of disease and a biomedical, understanding of what disease is. And more often than not, there is a paradox there that we tend to go along with whatever cultural interpretation of disease is. The third factor is something called self-efficacy, which is, can I perform the behavior that I may asked to perform, especially if that behavior does not conform with the behaviors that I'm currently practicing. Okay, do I have the skills? Do I have the competence? If I have that, then maybe I will practice those behaviors. Several smokers, cigarette smokers, perhaps want to quit smoking, but they don't know how to. So health communication can facilitate this behavior change. There is also, lastly, there is something called an optimism bias, which is, any adverse effect that will happen to me because if I smoke, because if I indulge in extra, marital affairs, I will not be infected, but if a similar behavior is being practiced by somebody else, that other person will be affected and not me. All of us at some time, most of us, not all of us, most of us, especially if you are young, tend to believe that, this is not going to happen to me. If I drive a car very fast, if I drive a two-scooter, very fast without a helmet, nothing is going to happen to me. But if we see somebody else doing the same thing, oh my God, what is this guy is doing? He will meet with an accident. He may perhaps die. This is optimism bias. There are other, incidental, constructs and variables that have been identified in the literature, which is, people, behave the way they do because they lack trust, in the authorities or the policymakers or people who are asking us to change behaviors. And of course, there is something called knowledge also, and I'll speak about that a bit later, that how knowledge sometimes does not have a direct and a very strong correlation with behavior change. So this is as far as the first part of my topic is concerned, why do people behave that they do? The second fundamental question that health communicators almost on a daily basis are confronted with is that can behaviors be changed? Okay, as health communicators, this is a question, that I should not be asking, but when we try to change behaviors, this is what we are always confronted with. And let me give you some examples. We ask, especially those who drive two-wheelers to wear helmets. Some of them do, some of them don't. Why is it that some people don't wear helmets? Another example, seat belts. It's more common now, but a few years ago, despite being reminded that you should be wearing seat belts, people still don't wear seat belts while driving. We still, when you're sitting behind in the car, you don't wear seat belts. Even when you have your children, young children, kids accompanying you, we don't tie seat belts for them. Why is it, that we don't do that when we know that the consequences can be fatal sometimes? Look at, there is enough literature, both medical and otherwise, which demonstrates that consumption of tobacco products, cigarette, bidi, gutka, chewing tobacco, etc., and there are several varieties of them, in this country here, is harmful, has adverse effects, can be fatal. There are television ads which show us, that this will happen to your lung, that, the gutka eaters have their parts of their mouth being, operated upon, Despite all this, some people continue to, consume tobacco products. And a common refrain, comment that we get to hear is, my father has been smoking for 40 years, nothing has happened to him, so how does science explain this kind of a thing that, cigarette smoking or tobacco consumption can produce, cancer of different kinds? So that's another thing. So how can we change behaviors, in this context? Something that has been referred to earlier, consumption of food items which are high in fat, salts, and sugar. Increasingly, children are being targeted. There is concern. We have never heard it until about 10 or so years ago about pediatric diabetes, etc., etc. But these things are now coming onto the fore. Non-communicable diseases is already a problem and is going to be increasingly so over the next few years. We have to live with that. How do we get people, especially young children, not to eat these items, which are known as HFSS items? Look at other kinds of things. Several of us refuse to interact with persons affected with leprosy, persons affected with HIV. So can we change behaviors? Can we get ordinary human beings to interact with persons who are affected by leprosy or affected by HIV/AIDS, and several other diseases that are stigmatized and people who are suffering from are discriminated against? Another example, especially from northern part of the country where I come from, early marriage and early pregnancy. Whole host of reasons given by families and communities as for getting their daughters married when they are 15 or 16 years of age. All of them by themselves, very valid reasons, especially from their point of view. And in that sense, very scientific at that individual level. Okay? How do we confront those kinds of behaviors? So we don't have answers. We have practices, but we have no answers, so I'm not answering any of these questions. So my third fundamental question now is, how can behaviors be changed? Can these behaviors be changed? What are these behaviors, and can this be changed? Several approaches have been tried, have been successful at times, and I'm going to identify 3 or 4 that are very common here. One is, of course, which is not communication, by legislation. Wearing helmets, wearing seat belts, tobacco in this country, child marriage, all have been legislated against. So legislation in certain health contexts, plays a very significant role and ensures that a significant part of the population, accepts such behaviors. So if force is required, if legislation is required, if legal provisions are required, I think they must be enunciated. 2 is, there are certain behaviors that change over time. We practice communication, we keep, educating people, we do social marketing, several other kinds of things. But there are some behaviors that change over time. And they especially change over time when service is provided. I mean, several of people were drinking, different, contaminated water. But when you supply piped water into households, people start consuming, the right kind of water. Water that is clean, that's pure, that is unadulterated. So what is it that's making a difference? Is it communication? It is social engineering? It is legislation? Is it something else? Or merely, as development happens over time, almost involuntarily, some people change their behaviors. And of course, education plays a very important role, which is a 4th factor. We know there's enough evidence in this country now that an educated mother, makes a great deal of difference within the household itself. Okay, so education indeed plays a very important role. So that was my 3rd question. 5 minutes remaining, okay? This is the last point. I thought I'd leave some time so that, my other remaining 2 speakers can take my time, but, there's another 5 minutes left. My 4th and last question. What does the science of persuasion tell us? What is the evidence that is available to us? It is not clear. It is not very precise. In fact, it is very confusing. But there are some broad indicators, there are some indications that tell us, that the science of communication and the science of persuasion works. So the first thing that the science of communication tells us is that knowledge has a very weak and tenuous relationship or correlation with behaviors. Let me give you an example here. When there was, I hope several of you remember that there was plague in Surat about 20 years ago or so. The first segment of the population that left Surat that essentially ran away from Surat were the medical doctors. How do you explain this? Somebody who is so knowledgeable should be the first, community to leave Surat. That's just an example, but, there were about 10 or 20% of correlation between, knowledge and behaviors. So this model of, knowledge will lead to attitude change, will lead to behavior change, does not actually, hold water in several, instances. It is actually the other way around. If you can get people to accept behaviors, if you demonstrate behaviors to them, and people, if they see benefit in those behaviors, if they accept those behaviors, then they change those behaviors. The doctor prescribes you medicine, the chemist gives you a medicine. You don't know how the medicine works in your system, but you still consume because you know and you have that evidence that, this medicine will cure my headache, my stomach ache, whatever you have. So knowledge doesn't always, hold good. That's the first, indication that we get. The second is that behavior change occurs under some conditions. Those conditions have to be identified, okay? So people, should have the necessary knowledge and skills, the ability to change, and the skills to change. No, sorry, not knowledge. The ability to the change and the skills to change are very important here. Then behavior change often depends on kinds of behaviors that beneficiaries are required to accept. If it is a one-shot behavior change that you want people to undergo, they will gladly do that. For example, vaccination, just one dose of vaccination, and people will do that. But if it is repetitive behavior, then, chances of behaviors being, discontinued are rather high. So that's another thing that we get. My final observation is a paradox. We are also living in a time when there is so much spoken about choice. There's a choice theory, that it is left to us. It's my choice to do this, it's my choice to not to do this. But what is good for you isn't good for the overall social good. And I'll leave you with two good examples here. If I have 3 or 4 daughters, if my wife is pregnant, and if I were to find out that that my wife is likely to give birth to another girl child, then you know what people do. Okay, there's enough evidence, there is feticide that happens there, infanticide or feticide that happens there. Now, it may be good for me, and there's a big question mark there, but if we were to do that, then what happens to the overall social good? So what is good for me is not necessarily good for the community. So perforce, health community has to address this, what's good for the community. And the second and the last example before I conclude is, repetitive vaccinations. If you vaccinate the child polio drop once, the family accepts. Second time, third time, fourth time, fifth time. Some madam gave an example of, measles, rubella in Tamil Nadu and Karnataka. The question that educated people generally are asking is, I have already vaccinated my child for measles. Why should I do it the second time? Why should I do it the third time? There is no credible answer for that father or the mother or the parent who is asking that question. But it is for the overall social and general good of the community. So these are some of the paradoxes, some of the questions, some of the issues that health communicators are generally confronted with. There are no ready-made answers. We sometimes have to invent some. We have to understand the cultural context when these behaviors happen. And I think, health communication, therefore, is an equally and an exciting area of work. Thank you very much.
Okay. Thank you, Dr. Krishnatre. I think you left us with a paradox of choice theory. What is good for me may not necessarily be good for the community, or what is not good for me will actually be good for the community. A thought to ponder upon. At the end of the session, we'll open the discussion for questions, and I think we'll take your questions then. I now invite Dr. Subba Rao for his talk. Dr. Subba Rao represents the area of nutrition research, and we have requested him to talk about how media represents food and safety issues. And I think Mr. Ketkar touched upon it slightly, that more than information, there's a lot of misleading information that a lot of us who are not from the medical fraternity are not able to decode. And we'd request Dr. Subba Rao to address that part of the discussion. Thank you.
Thank you, Dr. Rishi, and thank the Symbiosis fraternity for inviting me to talk on this. And as she said, there is a lot to talk about how media covers nutrition and food safety related issues. But for the talk today, I just made, a presentation on how food issues, food safety related issues are covered in media and how they turn out to be scarce, whether there is any connect or disconnect between what the experts feel are the risks and what the lay people, so-called lay people feel are the risks from foods. I source from a lot of our studies that we've conducted. Some, personally, I've been the principal investigator, some others from the institute in which I've been a part. And it's very nice to see a young audience and from different diverse backgrounds. I'll try and keep it as simple as possible. But before we start the presentation, I usually have a request to all the audience to stand up and touch the roof usually. That I do, because in nutrition field, we feel having food is as important as having physical activity. So we've had food, we've been sedentary for quite some time. I think we should stand up and stretch and then touch the roof. Reach the sky. Reach the sky. Thanks so much. There's a lot of young force here, unspent, and definitely they have a long way to go, and sky is the limit, and you can always try to touch the sky. And thank you so much. And that's what happens. And that's what happens with health communication. The sky is the limit, and there's a lot to explore. It's still an unexplored area. May I have my first slide, please? Is this the one? Do I use this to change slide? Okay. Oh, how do I get back? Yeah, right. Okay, let me give you a context as to what the food scenario in India currently is. As the speakers were saying right from the beginning, including Mr. Ketkar, that we have traditions and lots of centuries old traditions, and the way we prepare food, the kinds of foods that our family eats, our surroundings are there. These are all there, and with increasing availability of different kinds of foods which were not heard of, say, about 20-25 years ago, have come in because of economic liberalization. We have lots of foods. The food is also getting globalized. And we also have rising middle class, which is an example in India. And then high literacy levels these days literacy levels are generally going up. And then there are a lot of consciousness about health, food, and other things. And then media covers a lot of these issues. And then day in and day out, switch on the television in the morning, somebody tells you how to make a pakoda without oil. And still, somebody actually makes oil look a villain. And then a lot of things happen. And then we are exposed to all these things. And then there is, with international norms and then food crossing borders and then foods coming from other countries to us. And then there are certain, areas where the food norms are also getting, in the sense that in tune with the global food laws, because foods are crossing the borders. So labeling and other things are also becoming very important. The information related to food is being provided with an attempt that people make informed choices. And we also have modernizing retail in the country. Gone are the days when in urban areas people used to walk to the provision store next door and then buy whatever they want. Now we walk into big malls and supermarkets, and then we go to buy only one food, but we end up buying 100 other foods. Whether or not we are consuming that is a different issue, and then we end up definitely consuming something that we didn't intend to do. And then there are also lots of media campaigns about what is unsafe, chemicalization of foods and the foods becoming unsafe. And there are all of media campaigns about celebrities campaigning about the food, something that you cannot stop eating one. And then there are, hundreds of things. And then good foods, bad foods, not so good foods, whether food is good or bad. How many of you believe that food and health have a direct relevance and then foods can be good and bad? Yeah, I think, yeah. Are there any healthy foods and unhealthy foods? Yeah? Okay. The next slide, please. Okay. Yeah, let's see the, how food, where do we source food from? I said, in the urban environment, there's a change in the retailing business, and then we have foods available in different stores, but still, one of my colleagues, Dr. Sudarshan, says, more than 50% of the foods are still sourced from traditional sources, like, the open markets, the provision stores, the kirana stores, because not just in urban areas, but everywhere else in the country, you'll have to see how people are sourcing, foods. So these are two broad sources. If we categorize the food that we consume on a day-to-day basis, we eat home-cooked foods, and eating foods away from home is also becoming very important, and most of us consume at least once or twice a week away from home, and then we have these family gatherings happening and outings happening. We are eating foods outside, and then foods in the canteens, foods on the streets, so street foods. So home cooked foods, outside foods, away from home foods, and then processed foods, which are industrially processed, the packaged ones and the foods that are processed at the industry, sometimes ready